Our last speaker is Dr. Besser from Cambridge, who is going to tell us when our patients start bleeding, what investigations we should be doing, and how we should be treating them. Thank you.
Okay, thank you very much. So my name is Martin Besser. I'm one of the hematology consultants in Addenbrooke's Hospital. My perspective is essentially from the other side, from the side of the blood banker. And as opposed to other bankers, we don't get any bonuses and have significantly less fun. And these are my disclosures. Essentially, I wanted to start by showing you a video. We've talked a lot about the complexity of the coagulation processes when you're trying to stop bleeding. And this video, because I can't stop and start it at will, once I've started it, it will basically run through. I'll try and talk to it, but to not overwhelm you, I'll explain to you first what you're going to see. You see here an animation of blood and plasma at the bottom and a wall of cells, and you can just about see the surgical steel come in from above. You can see about the tip of the knife. And at the bottom right corner, just to give you an idea where you are in terms of the thromboelastogram parameters throughout the animation, you'll see a thromboelastogram form. And halfway through this presentation, there'll be a short pause where I'm going to show you the layering of the clot, which is a lot more complex than you initially believe. So I'll have a go, and if it's all too fast, we can always look at it again in the end. That was our surgical colleagues here. You can see a hole has formed, precious red cells are escaping, factor 7 has been activated, and now the other clotting factors are being activated, and this cloud of enzymes will now activate fibrinogen molecules and gradually form a clot, which I hope you will remember is mostly consisting of fibrin, polymers, and platelets. So this is what is going to give our clot the strength we require. You can see as more and more platelets jump into the gap, we actually get up to 7 different layers of platelets. The platelets that jump right into the breach deform significantly, and thrombin is the most important mediator in that area, whereas the platelets that are last to come merely aggregate, don't shape change that much, and ADP is very important in that zone. So the clot is a lot more complex than you initially think, and you can see also that the process of clotting is really determined by the right thing happening at the right time, and it's not as if you're able to just increase one component and get more clot. The reason why in the TEG you see a very good clot strength now is not just the static clot, but actually when you look at it with a fluorescence microscope and see the clot in action, that the platelets have muscle fibers within them, and once they've been connected by fibrin polymers, they're able to contract and give you a stable chewing gum-like substance which you're able to test out with your TEG. And finally, if you let the TEG run for long enough, if you have the patience, you'll start seeing fibrinolysis happening dependent on how active this process is in the patient. Essentially, you can boil this down to 3 main functions of your platelet. So taking out all the nice animations, you have adhesion of the platelet via glycoprotein 1b59 receptors to von Willebrand factor, which binds to the extracellular matrix. You've got aggregation of platelet to platelet with the help of fibrinogen molecules between GP2B3A. And finally, you have the function of the platelet as a workbench for the thrombin explosion to happen. So the platelet is important for taking your thrombin explosion to the area where this explosion is needed, so therefore you're able to have a very overwhelming catastrophic reaction right where it should be happening and not everywhere, so it's not a mere chemical reaction. And finally, the platelet, with help of muscle fiber, will form part of this fibrin meshwork. So this complex process helps us to stop our patient bleeding. However, our assessment of this process is I guess still in its infancy. I mean, platelets were discovered about 140 years ago after we were initially thinking that platelets are just dust on slides. We now know how important platelets are. But, I mean, the main test you all like to do is the platelet count. And obviously that's important. We are able to test the readiness of the coagulation cascade of the patient with the help of the PT, the APTT, fibrinogen, and we're quite fond of the thrombin time in Papworth. These, of course, are very crude tests. You're able to test the elasticity of a fibrin clot in vitro in combination with platelets with ROTEM and TEG. And you're able to modify ROTEM and TEG to something called platelet mapping, which is essentially the clot forming with inhibitors to the fibrin reaction and making the reaction critically dependent on stimulation of the other platelet receptors I haven't yet mentioned, such as ADP or thrombin. And also there is the multiplate, which has been mentioned a couple of times, an impedance aggregometer. which of course is able to assess both the action of ADP on the platelet surface and the action of cyclooxygenase in the platelet's inner workings. So what are we missing? Essentially, we're missing the response to physiological concentrations of clotting activators, so what actually happens at the site of injury. And we're also missing the dynamic process of localizing the platelets to the site of injury, which depends on the blood flow, so any assessment of this process in the absence of flow and anatomical factors is bound to be incomplete. And we also insufficiently assess adhesion. We're assessing aggregation, even with multiplate. We're not technically assessing the adhesion process, and also the communication between platelets is incompletely understood. And of course, there's anatomic factors. If you think back to my video, there essentially is a wound bed, there are mural areas of the clot, and there's the capillary itself, which you either want to or not want to obstruct. So thrombin generation was mentioned by my colleagues. The main advantage of thrombin generation is that you're able to assess the reaction of the patient's plasma or platelet-rich plasma at the minute in response to a much lower dose of tissue factor in the order that your body actually encounters at the site of an injury. And therefore, dependent on the clotting factor signature concentration, which is individually highly variable but fairly constant, you're able to see with the help of a fluorochrome how much thrombin this patient is able to produce. And you can see that a bell-shaped curve like that, you have 4 main parameters, with the peak probably being the most sensitive parameter of thrombin generation to reduction in clotting factors. And you see patients with different thrombin generation potentials going through surgery and having a differential bleeding phenotype. There are studies that have shown that the intraoperative and postoperative bleeding phenotype can be predicted by thrombin generation. One of these studies by Coakley has also hinted that maybe preoperative you're able to predict what's going to happen, but of course there's problems with that, and we'll come to that in a moment. There are numerous tests of what happens with your clotting factors after cardiac bypass. And since I've lost my office this week, I was inspired by the stretcher in the patient room I had to use during the week. Essentially, if you measure any clotting factor, any enzymatic clotting factor at the time of cardiopulmonary bypass, you have at induction, which is the first time point, a normal level. You have a massive reduction in the thrombin, in the enzymatic level at the beginning of bypass. You then have persistence of this, possibly slightly lower than at the beginning of bypass, at the time of giving protamine, and finally you have a slow recovery during the time in ICU or the post-operative time. And you can literally draw a graph like that for any factor that is an enzymatic factor in the clotting cascade you care to measure. And studies have been performed numerous times. With the study by Wayne Chandler, it's probably one of the most thorough ones, but there's numerous repeats of this. And essentially this is what clotting factor activity looks like. There's a second graph that you can draw, and that is of fibrin polymers and thrombin activation in the course of cardiopulmonary bypass, which is essentially convex shaped like this, with a peak of the thrombin generation and fibrin monomers having formed at the time of you giving protamine. So essentially, despite your humongous doses of heparin, you have got a degree of clotting factor activation, and this, at the substrate level and the final terminal enzyme thrombin, you get an increase followed by a decrease. And these studies also share another feature, that you have a relatively tight-knit group at the beginning. So the standard deviation in your cohort, this would be true for both these graphs, is relatively small. And as the surgery progresses and as the surgeon does his operation at the end of bypass, there's a big difference between patients having gone through the same standardized operation. So in summary, essentially you start with high clotting level factors and end up with low factors. However, your thrombin levels are high, so I'm not talking about prothrombin, which would be also low, but the activity of thrombin is high. So you've got a discrepancy compared to the beginning of the surgery and compared to us sitting here in the audience, that a very high level of thrombin is dealing with a much reduced level of substrate. And you have a high degree of inter-individual variation at the end, but not at the beginning in the majority of the studies. And this action of a lot of thrombin on reduced substrate levels is very important to understand a lot of the findings that we deal with. And the problem with any study that tries to predict what's going to happen after the surgery is the big variance, which increases throughout the time of the surgery. And it's almost like trying to predict the future by just looking at preoperative clotting factor levels, because there's such a big human factor in the middle. This is a study, again, just to prove the principle. This is a study in PTE surgery where we measured platelet counts throughout the procedure in 20 patients. You can see my stretcher model works here. And if you measure by multiplate the response of these 20 patients to thrombin receptor activator peptide, which is a thrombin analog, you can see that initially, if you ignore the first time point because that was used for standardization of the y-axis, you have a relatively tight-knit control, and you have a huge variation of the shape of the curve at the end of surgery, which is probably to do with surgeon and patient factors. So we know this is going to happen in our patients, and we would quite like to interfere, but if we play devil's advocate, why should we interfere with this? Because it's going to get better, isn't it? And the problem, just from the hematologist's perspective, and something that is increasingly frustrating me, is if you have 3 patients, and in theatre 2, the surgeon decides that there is too much bleeding, therefore the junior doctor sends off a variety of tests, be these point-of-care tests or conventional tests, you will find an abnormality which you can treat. And you think, yes, I've cracked this case, I've done the right thing, I'm treating this. But if you had tested patients in theatre 1 and theatre 3, you would have also found an abnormality you could have potentially treated. And it's a complete... it's a difficult thing to predict whether these 2 patients will also get treated, because it depends on the assessment of the surgeon. And the problem with junior doctors and with workload is that they obviously want the surgeon to have a clotting experience of a lifetime, and therefore they're very keen to make sure that all our patients' clotting has been optimized, which is a very expensive thing to do if you detach this from the clinical picture. And for me, sitting on my chair in blood bank, having my cup of tea, I cannot see how much the patient is bleeding. And every patient, the reason why we issue any blood product is always bleeding when I come back after the weekend. So it's very, very important to make sure that you transfuse and test for the right reasons. This is a study similar to what we saw earlier. This is the American experience by Bennett Guerrero in about 100,000 patients retrospectively in 2008 across 800 centers in the US. And you can see the same that we saw earlier in the blood use audit, that the hues of red cells on top and FFP at the bottom, platelets, etc., would be very similar shape, very hugely, and places that do lots of surgery, so very far right on the x-axis, use far less blood products than centers that use little. And the interesting thing is that all these 800 centers are operating, none of them have been shut down, so therefore the outcomes can't be grossly different. And the problem is now, if you want to introduce a new test or compare your performance with your testing, your coagulopathy assessments and treatment, if you compare yourself against the Red Star Center, you're going to get very different results if you compare yourself to the Green Star Center. And if you're in the situation of the trust that excessively uses products, any intervention that potentially reduces the decision to transfuse, be it just cutting the phone lines for 8 hours, will significantly reduce the amount of blood used. And whether or not this has a bad effect depends on how inappropriate you were to begin with. And that's a huge problem with any retrospective assessment of the use and treatment of blood products, and is also seasonal in our hands, because we get a lot of junior doctors come through, and a lot of the teaching and agreements are frequently forgotten throughout the year, and it doesn't project so well. Essentially, most clotting factors, if corrected, have a continuous effect in vitro on clot stability, be it factor 13, be it fibrinogen, etc. But the financial effect, so that's the bit that hurts me, is essentially exponential, because if you get more generous with your fibrinogen threshold, you will correct more patients' fibrinogen levels, whether or not they needed it, because there is, as much as you try and stratify, a trend to test more people, and this will increase the cost for this particular factor, and you have to have quite a drastic response to this new treatment in order to get your money back. The main problem is today not whether inter-individual assessments of coagulation in a patient is superior to the machines, but the problem is whether laboratory-based machines or point-of-care-based machines are better. And essentially, both of them introduce a time factor, but both of them are probably better than just a simple human assessment whether or not this patient has coagulopathy. But the jury is out which one is better. Increasingly, there are more studies showing that blood use reduces in the point-of-care setting. However, there's a major degree of bias. There's 4 important studies that were done in the last couple of years. However, 3 of these studies which showed both improved outcomes and reduced blood loss come from the same group. And the fourth one also uses the same algorithm. It's a very good algorithm, but it includes treatments that are specific for the German hospital setting. That is including factor 13, it includes Nova-7, it includes prothrombin complex rather than FFP, it includes ROTEM modifications such as the XTEM, the INTEM, and the FIBTEM, which are all obviously very useful, but may not be exactly a pure effect of the point of care algorithm, but probably more an effect of the whole package. And it's important to be aware of this and be cautious rather than blindly introducing tests that are potentially much more expensive and lead to changes in transfusion practice. And it's very important to be careful what will happen to your blood budget as well as outcomes. And XTEM and FIBTEM essentially are modifications of the TEG that make the TEG a lot more similar to either the PT or the Klaus fibrinogen, so I should say the ROTEM, and functional fibrinogen is the equivalent on the TEG. And what you have to bear in mind, however, when you use the published thresholds for FIBTEM, which is about 8 millimeters, you are by stealth also introducing a Klaus fibrinogen that is close to 2 grams. So you're going from the conventional recommendations of near 1 gram closer to 2 grams. And the high correlation between these tests does not necessarily mean equivalence. And here's an interesting study by Solomon in a small group of patients at the end of cardiothoracic surgery. And you can see that if you compare the performance of FIBTEM on the y-axis with Klaus fibrinogens on the x-axis, which is the laboratory-based analysis, there's good correlation. However, the FIBTEM level of 8 is close to 1.5 to 2, depending on method. And another really interesting finding is these are also patients that receive 2 grams of fibrinogen. And you can see that the pre-column, which is on the left, the slope of the correlation is different from the post-column. So there's something about inducing the fibrinogen level with fibrinogen concentrate that isn't quite the same as just moving up and down the fibrinogen level curve, which is very interesting and reflects some of the things we find in clinical practice. I'm not going to recap where the fibrinogen level should be. It should probably be higher than what we have been doing, but there is no 100% guidance, particularly in cardiothoracic surgery at this point. There's a Cochrane review from August 2013, which essentially whittles down the number of trials and patients treated with sufficient rigor in 6 randomized controlled trials to only 248. And there is an indication towards reduced blood loss, but whether the reduction in mortality follows will have to be seen with some of the trials that are currently ongoing. So this leads us nicely onto the interventions, which I'm going to cover towards the end of our talk. The problem is that the 2 most common interventions in our hospital, platelets and FFP, are fairly low quality interventions. FFP is quite interesting. Nobody really owns up to having invented FFP, and is more a product of convenience, which was used in the war effort of Britain and America against the Germans to try and get American blood across the Atlantic without the problem of the storage problems when you try and do this with red cells. However, it has entered clinical practice, and we now use 15 units per kilo as a standard dose. The dose is not based on efficacy, but it's based on the fact that with your 15 units per kilo, you also give 15 mils per kilo of water. And if you think of your existing plasma volumes, which is about 40 mils per kilo, you increase this by nearly 50%. And therefore, in a patient who has no clotting factors, increasing the clotting activity with the level of water that comes with it initially, you can get an increment of up to 30% before you're able to eliminate the excess fluid. If you do this in a patient who only has minimal reduction in his clotting factors, the increment in clotting factor activity with 100% of 15 units per kilo clotting factor will be minimal and be closer to 10%. Similar for platelets, a unit of platelets supposedly contains a minimum of 250 billion platelets. This obviously is a very nice gift if your patient has no platelets at all. However, if the patient already has between 1 trillion and 1.2 trillion, you can imagine that the relative increment will be much less. And you have to ask yourself, if you have a patient who has got residual clotting activity or residual platelet counts in excess of 50, whether you're actually doing a very sensible thing and whether you should really rely on blood products or whether you in fact are potentially missing other problems that may be interacting here. And the coagulopathy certainly is not helping, but may not be the main reason. So to cover some of the other interventions, prothrombin complex is essentially higher quality FFP, except it only contains protein C and S on the anticoagulant side and has high concentrations of factors 2, 7, 9, and 10. This is a very good intervention if you have a patient who's lacking in 2, 7, 9, and 10 because they're vitamin K deficient or because you've given them warfarin. If that is such a good intervention in a patient who lacks all clotting factors or has minimal abnormalities in their clotting screening tests, is not so clear, and this product has been around in various permutations for more than 50 years, and literally in all generations of this product, but the last, there were at some point major concerns with regards to the prothrombotic risk, particularly if administered repeatedly, and you should use it cautiously unless you're treating a defined defect. Factor 13 has generated a lot of interest and is used in some countries still. However, in a randomized controlled trial of recombinant factor 13, there was neither effect nor side effect, and quite ironically is present in cryoprecipitate. So as much as we're trying to move away from cryoprecipitate and move towards fibrinogen, it is actually present in the product that we've already got. Tranexamic acid, again, there's dispute how good a product it is. There's a Cochrane review that it does reduce red cell use and re-exploration. However, it's not universally shared, and one of the problems with tranexamic acid is that we're treating prophylactically and prescriptively, and we're not looking for evidence of hyperfibrinolysis because we have no rapid test for hyperfibrinolysis that is universally useful. I'm not going to cover protein again, and DDAVP was mentioned before already. Problems with DDAVP is that some of the evidence is outdated. There's good evidence for the hypotensive reaction, but of course that's not what we're looking for. And a DDAVP is essentially a nice measure that is not a blood product that is able to release your endogenous von Willebrand's factor. Whether or not this works or not will depend on how much von Willebrand factor you've already released and on the type of bleeding you're trying to treat. And finally, there's of course NOVO7, which is active but dangerous and should really be a measure of last resort only if you're going to use it at all. This is my next to last slide, and I just wanted to show you this study. It's not really a study you can very well cover in a setting like this in under 20 minutes, but it's a very nice paper to look at because Ogawa and colleagues with Tanaka involved as well have used a flow chamber, and they used in the top cluster of microscope photographs high flow conditions and low flow conditions in the bottom cluster. And on the bottom right, you can see a picture of the flow chamber. You have a blood depot that trickles blood into a capillary and finally goes past a microscope, which you can just see at the lower border of my slide. And essentially, you can see that interventions in blood, and they use both diluted blood and cardiothoracic surgery blood, the effect of interventions depends on your flow conditions, and it depends on which area you would like to work on. So you can see the photos stop being projected here when the flow in the chamber has stopped, that you can see stop of blood flow after 6 minutes in the controls, and blood flow continues for more than 9 minutes in the dilution model, and you can see shortening in the von Willebrand factor administration in the third row on the top cluster after 6 minutes. However, in the low flow pattern, von Willebrand factor doesn't do much at all, and in actual fact prolongs the bleeding problem. And again, fibrinogen has a good effect in the low flow chamber, but not so much in the high flow chamber. And as a surgeon, I think it's important to think back whether you left high flow or low flow conditions behind when you closed the chest. It's very important to pick your intervention based on which intervention is probably most best suited for your patient. So I'd like to conclude by one of my favorite statements from one of the cardiothoracic surgeons, one of the pioneers. Since we've never encountered post-operative hemorrhage due to abnormalities in the clotting mechanism, platelets are no longer part of our routine patient care. And the occasional instance of post-operative bleeding that we have seen has been accounted for on a basis of inadequate hemostasis, and since recognition of the importance of more meticulous hemostasis in these heparinized patients, unusual bleeding in the chest has not occurred. And it shows you the basic dilemma we still face, that we have both surgical and hematological problems, and only in partnership can we solve it. And I thought I'd crack a final German joke. Let's see if you agree with this one. Essentially, a good surgeon doesn't need platelets, and a bad surgeon doesn't deserve them. So with that, I'd like to conclude. Thank you very much.
Thank you very much indeed, Dr. Besser. I'd like to invite the rest of the presenters to come and sit with me on the panel, and we'll take some questions now. Professor Taggart.
Thank you. I'm often intrigued in our operating room when we routinely do TEGs on all patients, whether they're done on or off pump. And I'm absolutely convinced in my own clinical experience that I can tell whether a patient has a bleeding problem about 5 minutes after the operation has started, and that's because if the skin edges are still bleeding, there's something wrong. And I will then ask the anaesthetist, is there a hematoma around the central venous line? And if these two things are present, that patient, I think, has some problem with the clotting. The problem we then get into is someone comes into the operating room and says, we've done a TEG and it's normal, so therefore that's it. Or alternatively, you see the opposite. You see sometimes someone will come and say a TEG is abnormal when you can tell from the skin edges that things look absolutely fine. So I'm not sure. To me, I guess that's bleeding time that we're looking at, and to me that's a very clinically reliable way of guesstimating whether you're likely to have a coagulation problem. And the second thing I would like to wonder about is, of all of these studies that people have mentioned, are these would the same findings hold if these patients were done off pump, or are these studies specific to patients done on bypass? Thank you. By the way, I enjoyed all the presentations.
So if I could address your first point, Professor Taggart, can I just check that what you're actually saying is that this is a strong argument for the adoption of level C evidence into guideline development?
Absolutely, in the same way that if you ever jump out an airplane, go for 1C evidence for a parachute. Strongly recommended.
I just thought I'd clarify that at the outset. Okay. Dealing with the second case, there's very strong evidence you don't get the same level of coagulopathy in off-pump surgery. I think that's, I mean, whatever your dispute about the benefits and risks of off-pump surgery, it's clear they bleed less. I mean, anecdotally, I don't stop ticagrelor or Prostagel in off-pump surgery. I don't have a problem with bleeding. But if you do it in a patient that you actually have to put on bypass, they just bleed and bleed and bleed. So, but I don't know what evidence there is. I don't know if any of my colleagues would like to comment on that.
Yeah, I think one of the problems is, and it is difficult teaching surgeons this, that you're talking about hemostasis, and you're then discussing that in terms of a coagulopathy. Okay, the patient can have abnormal hemostasis, and they can have a coagulopathy. So, I mean, you can do this yourself tomorrow, or whenever you go back to work. When you've got your patient, and you've given them the full dose of heparin, whatever that full dose is, the blood will not clot. Get somebody to make a small nick in the skin, and get someone to push on it for 5 minutes. Push on it. The ACT will still be running. It will not have formed a clot. When you take your thumb off the thing, it has stopped bleeding, right? So you don't get hemostasis. You don't need to have a coagulation system. And that's one of the problems that we have. So when you're talking about abnormal bleeding from the skin edges, that's because you've got some platelet endothelial cell misfunction, which, as far as I know, we don't have a test for. We can't test for that, and therefore you can't say if that patient is or is not abnormal. All you've got then is, I think, as Gavin said right at the beginning, coagulopathy is a clinical diagnosis. You know the patient's coagulopathic because you look at it and think, that doesn't look normal. But that's as far as, there isn't a measure we've got, is there? There's no machine for measuring this.
David, I was specifically meaning looking at the skin edges before you've heparinized the patient.
Yeah, but we can't measure that.
No, sorry.
And as Gavin says, if you look at the studies which have looked specifically at bleeding time preoperatively, not one of them has ever been correlated or associated with abnormal bleeding afterwards. So bleeding time doesn't help us in the randomized studies that have been looked at.
Any further questions from anybody? Okay, well, in the interest of time, because we have overrun, I'd like to thank all the presenters for their talks today, and I hope you enjoy the rest of the day. Thank you.